Hi there, my name is Louis Grandjean. I am a consultant in paediatric infectious diseases and an associate professor of infectious diseases at UCL. And first, I just want to say many thanks for the opportunity and the invitation and the chance to give this talk to the Paediatric Society of Hong Kong for your annual scientific meeting. So many thanks indeed to Dr. Ip and Mike for that invitation. So without further ado, I'll get on and share my screen. So I've been asked to talk today about our experience of PIMSTS. So this is the Pediatric Inflammatory Multisystem Syndrome, temporarily associated with SARS-CoV-2. Apologies in advance if my children or the cats walk in through my talk. I'll do my best to work around that, and I'll try and stick to time. So first, I just wanted to say, and I showed this talk before in the Bill Marshall, I showed this slide before in the Bill Marshall lecture I gave last month, that we clearly are still not learning from our friends in Hong Kong when it comes to the management of COVID in the UK. It's deeply upsetting and rather embarrassing, the number of cases that we have had compared to you guys, and I think that there's many reasons for this, of course, but one of them is certainly behavioural in my mind, and we simply aren't used to wearing masks on a large scale, and have only just got used to doing that. So we're catching up now, and hopefully we'll be able to deal with COVID a little bit better in the future through mask wearing and a whole bunch of other measures as well. But yeah, plenty to learn from you guys. So I'm going to talk about PIMS-TS. I'm going to give a case study of one of the cases that we have seen at Great Ormond Street that's hopefully of interest. I'm going to talk about some of the presenting features that we have seen, what we are doing in terms of the management so far, and also talk a little bit about some of the latest research that we're doing at Great Ormond Street. So we've seen, unfortunately, about 85 children since this all started in April, May of 2020. And I remember, because I was on call the weekend it all happened, and there were 4 or 5 ambulances waiting to come into intensive care with exactly the same presenting child. And with the same presenting features of fever, rash, conjunctivitis, abdominal pain, very much like a Kawasaki disease, but in slightly older children. So not in your kind of 2 to 5 years where you would, 1 to 5 where you commonly see Kawasaki's, but this is age group was more 6 to 13 or 6 to 16, that kind of age. They presented with shock, myocardial dysfunction. Some of them had coronary artery dilatation, and very often they had gastrointestinal upset, right iliac fossa pain, and characteristic blood markers that I will go on to talk about in more detail in a moment. And the majority of these cases were SARS-CoV-2 PCR negative, but then had a positive serological test. And had a clear history of a COVID contact, usually about 4 to 6 weeks prior to their presentation. So this is a particular case that, in fact, I've only just, is in fact still in hospital now, actually, and I admitted him a couple of weeks ago to our intensive care from the local hospital, the referring hospital. He's a 10-year-old boy, and he had fever for 7 days already prior to appearing and coming under our care. He had classic conjunctivitis, macular papular rash, mainly over the trunk, and he had known COVID contact 4 weeks prior to his admission. Interestingly, and I'm not sure if this is relevant to his presentation, but 3 months before his presentation, he had had an appendicectomy at his local hospital. His father is of Indian descent, and we have certainly seen a preponderance of children from this ethnic background presenting with more severe features. There was no travel because we've all been locked down for months. There were no pets. There was no joint pain and swelling, no real significant past medical history, no family history, and he'd been fully vaccinated. When I saw him, he was talking, but he was really quite profoundly hypotensive, particularly diastolic hypotension. And his pressures were 60 to 70 over 20 to 30. And so he was requiring noradrenaline, despite being despite having no oxygen requirement and talking to me. And I've seen this quite a few times in these PIMS patients when they come in. They can look pretty well, but they can have really quite profound hypotension and vasoplegia. He was definitely febrile, spiking up to 40 degrees, and I'll show you his chart in a second. He didn't need any oxygen. He had conjunctivitis and all the other features that I mentioned before. His Glasgow Coma score was 15 out of 15, and all other examinations were pretty much normal, apart from he had a slight left lower lobe consolidation and pleural effusion. So this was his chart, and bear in mind that he has already been spiking for 7 days up to 40 before coming to us. And you can see that here on the 11th of October, 12th, 13th, 15th, 17th, he continued to spike despite all of our interventions. And I've just put how we intervened on the chart here so that you can see. Because these children present very much like a Kawasaki, and because we have seen aneurysms appear in the past, our tendency has been to give children 10 milligrams per kilo of methylpred on presentation. And in fact, we give them 30 milligrams per kilo of methylpred if they have aneurysms at the outset. But this boy on his first echo didn't have any aneurysms. And then 2 days later, despite giving him 10 per kilo of methylpred, he was still spiking. I should say he had already received a dose of IVIG at his local hospital as well. And so we upped him to 30 milligrams per kilo methylpred. And despite that, he was still spiking and hypotensive and in and out of intensive care. And so we switched into 2 milligrams per kilo twice daily of anakinra, and very gradually his fever started to settle. You can see at the outset that he had really quite significant neutrophilia and a lymphopenia of 0.82. His other cell lines weren't too bad. He was slightly, he had a raised ESR, wasn't particularly thrombocytopenic, and he was slightly anemic. In terms of his CRP, it was really quite markedly raised at the outset, up to 350, and we have seen children with CRPs, record-breaking CRPs in the 500 range. And we got on top of that CRP reasonably well with the methylpred at 10 and then 30 per kilo, but it got down to 50, and he was still grumbling at 50 for quite some time. So we didn't completely switch off the inflammation with our interventions quite as quickly as we would have liked. Unfortunately, all of these kids, being as we are a tertiary hospital, end up on antibiotics despite being culture negative. And you can see here we've got this lovely system at Gosh called EPIC with timelines, and at the bottom we have all of the cultures results of the urine and blood and when they were taken, and if they flag up red, then they are positive. And you can see essentially at the bottom there are no positive cultures, and despite that he got really quite a long course of antibiotics, which were then ramped up over time when he was not clinically responding to the treatment. So that's another shame but it's a necessity, unfortunately. But it is a shame that many of these patients receive quite broad spectrum antibiotics for long periods of time. And they often have really quite high ferritins, and in this particular case, his ferritin wasn't hugely high, but it was raised at 600 maximum. We've seen them go to 20,000, 30,000, and present a little bit like macrophage activation syndrome. His albumin was really quite profoundly lowered at 20, 22, and this did not help his left pleural effusion, which worsened actually during the course of treatment. And his fibrinogen was also raised, which improved, as you can see, over time. Now, what was very interesting about this case on a personal level is that when we first tested his, we test them all, of course, for COVID PCR, which invariably comes back negative. We test the stool, we test from a nasal swab, and then we sent the serology, and we sent the nuclear protein antibody serology, and that returned negative. So we started to double guess, we started to double think, second guess ourselves, and thinking about alternative diagnoses such as lupus, such as toxic shock, etc. Because his serology was negative. However, if you look at this graph, and this is a graph of some of the research that I've been doing recently with colleagues in the CoSTARS project, you can see that this blue line here, and this is on the x-axis, we have time since the infection here, and this is the sensitivity, essentially, of the diagnostic test when tests become negative. And this is the nuclear protein assay that we had been using at GOSH a while back. And you can see fairly rapidly that after time from COVID symptoms, that this assay does not detect the antibody for very long. And so what we then did is we repeated a different assay on this child. In fact, we didn't do these two tests at the bottom are ELISAs. We undertook a chemiluminescent assay by MSD for the spike protein antibody, and that was positive. And you can see that the spike protein, I'll talk a bit more about this in a second, hangs around for considerably longer than the nuclear protein antibody. So that's really interesting, and we diagnosed this boy on the basis of this knowledge. So just bear that in mind if you see these kids. So this is data from a study from Alexandre Belot in France. He sent a letter to the New England Journal of Medicine, and you can see here the number of hospitalizations with COVID, and then superimposed upon that you can see the number of hospitalizations with PIMSTS. And you can also appreciate the delay between the two curves, in that it's approximately, about 7 weeks between the uptick or the peak of COVID and the peak of PIMSTS. Let's see, 1, 2, 3, 4, maybe 6 weeks from one to the other. And that corresponds precisely with what the children and their parents tell us in the history about their presentation. So after quite some time of seeing these children, the Royal College of Paediatrics came up with a case definition, which I won't labour the point in going through in great detail, but suffice to say it includes all of those clinical features that I have mentioned before. And then, of course, the CDC comes out with their own slightly separate, subtly different definition, including many of the same features with slightly different age range. And then the World Health Organization then comes out with their own definition, which again is different to the other two definitions, but broadly contains the same information and the same presenting features. So what is PIMSTS? Well, the answer is we don't completely understand the pathogenesis of PIMSTS, and there's a lot of active work going on to try and elucidate that. Similar to other pediatric inflammatory conditions we see, such as macrophage activation syndrome or Kawasaki disease, usually occurs, as I said, 4 to 8 weeks after SARS-CoV infection or exposure. We see kind of features of a cytokine storm, sometimes with raised IL-6 and IL-1 and CRP. There's a whole range of spectra of severity, and we really do see quite profound vasoplegia with diastolic hypotension, and often they present with an appendicitis, and many of our kids have actually had their appendix removed before they come to see us. So what else do we see associated with PIMSTS? We also see widespread thrombosis because of the hyperinflammation, and so all of our children get put on low molecular weight heparin as thromboprophylaxis. We have seen probably 5 or 6 cases with coronary artery dilatation as a result of the inflammation, which is why we are quite aggressive with our steroids up front. We've seen ferritins between 4,000 and 60,000, as I've mentioned, and very high CRPs. And we tend to give these children aspirin as well at low dose, as per the Kawasaki policy that we have, to have antiplatelet effect rather than at low dose, rather than the anti-inflammatory higher dose aspirin. There's many unknowns which still remain to be resolved. First, I think we've pretty much established that it's rare for there to be, for us to detect virus in these patients. And so it is really a pure host response. We also need to establish the risk factors. I've mentioned already that we have seen a preponderance of children from India and Pakistan and the Middle East. The age range is between about 4 and 16, but we still need to define the pathophysiology and the biomarkers, and also get a better handle on what the best treatments are, and immunomodulatory drugs. What indeed are the long-term outcomes, and what implications does it have for vaccine development? So as I've mentioned already, this is our approach to treatment. If they're very mild and they're well, then we may do nothing or just give them IVIG. If they are moderate and they're really quite sick, requiring hospitalization, then we will give them IVIG and 10 milligrams per kilo of methylpred for 3 days, and then start weaning that. If they're severe, particularly if they have coronary artery aneurysms detectable, then we will give them IVIG, 30 per kilo of methylpred, and then we will start to think about whether they need other immunomodulatory drugs. And we don't know which the best of those are, but as you all know from the recovery trial in pure COVID, pulmonary COVID, dexamethasone has been shown to significantly improve and decrease mortality. So there is evidence in primary COVID infection that dexamethasone benefits, and so we, and I personally believe that prednisolone plays a real role in the improvement of these patients, and we get them onto prednisolone pretty quickly. But as to the other immunomodulatory drugs, we do not know how they're going to benefit and which to choose. So what are we doing right now in the hospital to deal with this? Well, we're investing in high throughput PCR technology and antigen testing, as well as serological testing, so that we can rapidly diagnose many of these cases at a time. There's many things that we need to find out, such as how long will our antibodies remain detectable following vaccination? What is, in fact, the natural response to natural infection, and how long does that last? And we need to integrate this approach with occupational health going forward for our staff at the hospital. We have been involved in recruiting children to the world famous recovery trial, which has been great. And this is just to say that in my personal opinion, there is no equipoise for steroids in these patients. I like to treat the inflammation up front with steroids, but there's certainly much more work that can be done on other immunomodulatory drugs, such as anakinra versus tocilizumab. The other thing that we're doing now is we're just about to go into a second lockdown in the UK, which is awful. And you can see the graphs here that we have 25,000 daily new cases, and the second peak is considerably larger than the first, mainly because we're doing many, many more tests than we did previously. And you can see the hospital numbers are rapidly increasing. We're now at 12,300 in the last week. So that's a great shame. And it looks like we're going back into those dark days of the first wave, and that we haven't learned a great deal about how to control this, other than to have widespread national lockdowns, which hopefully will get to control of it. And last week we had 492 daily deaths. And so we're just hoping to hold out really until a decent vaccine comes along. And then finally, I just wanted to sum up before I finish with some of the latest results from the research studies that I've undertaken at Great Ormond Street as part of the CoSTAR study, where we've tested around 4,000 staff members at the hospital with COVID serological testing, and we can see that amongst our cleaning staff, and actually oddly amongst our computing department, we had really quite high prevalence of between 40 and 50% seroprevalence to COVID. And in fact, those two groups also had the highest antibody titers to COVID, which to me suggests that they have had repeated exposures, almost like boosting with vaccinations when you're exposed not once but on multiple occasions. This is showing a similar graphic to show that the cleaners, caterers and porters have about 2.5 times the risk of all the rest of us. Nurses, doctors, allied health professionals and scientists have a similar risk. And then we've done some of the COVID pathogen genomics, and this is a very small graph, so I'll just log in. But in our hospital, there has been considerable spread of COVID from staff to staff. And when we do the COVID phylogeny, I'll zoom into this, I'll see if this works. This might not permit me to do this, but at the bottom of the phylogeny here, you can see coloured faintly in light blue is the Great Ormond Street Hospital outbreak. And you can see lots of strains which are genetically very, very similar to each other in a distinct part of the phylogenetic tree, which is evidence of ongoing staff to staff transmission. Now we are wearing masks in all areas across the hospital, and so I'm really hoping that the staff transmission will decrease. And then this is data that I'm hopefully just about to send for publication this week, but this is about the duration of antibody responses following SARS-CoV-2 infection. And as I have alluded to before, you can see that on the left of the image here, this is the time from the start of your symptoms. And you can see that the spike antibody lasts, and this is the real raw data in our cohort, for 200 days and probably many more days. And when we modeled it, it looks like the spike antibody would remain indefinitely in the blood under this gamma decay to plateau model. And even under a gamma decay model, the spike antibody lasted for 400 plus days under those predictions. So that's, to my mind, is good news for our long-lasting immunity. Whether it will protect us from reinfection, we don't know yet. Hopefully, it will take the edge off future re-exposure and infection in terms of severity. But what we do also see is the nucleoprotein rapidly decays within a couple of 200 days. And you start to see negative tests occurring exactly as occurred with our boy in the case presentation. So very important when you're doing your serological testing that you've got the right test, the right assay. Chemiluminescent assays appear to be much more sensitive than the ELISAs, and spikes, similarly, spike antibodies seem to be much more sensitive than the nucleoprotein assays. So that is the end. I think it's more or less about 25 minutes. So as this is recorded, I don't quite know how I will be able to answer or deal with any questions, maybe by email, but feel free to get in touch through Mike. And thanks very much again for the invite and the opportunity to speak to you all. And I'd like to say thank you to the many people who were involved in collecting the data as part of the CoSTARS study. So thank you very much indeed.